Chapter 37, musculoskeletal trauma, is what we do for a living every single day. If you're going to be a nurse, this is your patient you're taking care of. Some of the basic concepts, your muscles, bones, cartilage, tendons, and ligaments are all part of this system. You have 206 bones in your body. Those could be cortical bones, which are dense, or trabecular, spongy, cancellous type bones. These are a little bit more susceptible to osteoporosis, which is where you start losing bone density. Osteogenesis is bone growth. Bone growth. The skeleton continues to grow until you're about 25 years old. The way I remember osteogenesis is there's a problem, a disease process called osteogenesis imperfecta. I don't think that's even in the book, to tell you the truth. Osteogenesis imperfecta. If you enjoy superhero movies like I do, the main character, main bad guy in the movie that started with Split, that movie Split, DC Comics world, and the most recent one's called Glass. The main arch villain had osteogenesis imperfecta, which basically means he has problem with bone growth and bone density, and he just breaks his bones very easily. That's why his supervillain name is Glass. So osteogenesis is that process of the bone getting stronger. When babies are born, their bones are not very calcified. They're mostly rubber. They're more like cartilage than dense calcified bone. So babies are pretty bouncy. They don't tend to break bones. And when they do break bones, it's not usually a clean break. It's often some kind of a variant, like a green stick fracture. And so that's because kids, their bones are not calcified and hardened yet. They're mostly cartilage. You have different bone cells that do different things. The osteoblasts are bone forming cells. The opposite of the bone forming cells are the osteoclast, which is called bone resorption. So your bones are constantly moving calcium in and moving calcium out, basically getting stronger or getting weaker. They're not a static entity. And the only real way to encourage an increase in bone density, we try to get people to take calcium and vitamin D supplements. But in reality, weight-bearing exercise is the only way to keep bones dense. So if we have a person who's bedridden, laying in bed, they're losing bone density every hour that they're laying in bed. Weight-bearing exercise. So if you are female, about the age of 30, you lose bone density every single year, starting about the age 30. A simple way to prevent that loss of bone density is weight-bearing exercise. Weight-bearing exercise stimulates those osteoblasts, which are responsible for forming new bone, keeping your bones strong. There's pictures in the book about that, how the osteoclasts and osteoblasts work together. Your peak bone mass is about age 30. you do need calcium and vitamin D, but the calcium and vitamin D don't help much if you're not also walking around. Walking really is the best weight-bearing exercise. The skeletal muscle are composed of fibers. You have myofilaments called actin and myosin. Then you also have tendons and ligaments. The difference between tendons and ligaments is that the tendons attach muscles to bone and the ligaments attach bone to bone. A big thing with a tear or an injury of a ligament or a tendon for that matter is they can take just as long to heal as a broken bone. So if you sprain your ankle, you may have stretched out some of those ligaments. Hopefully you didn't tear one, a tendon or ligament, but you could have stretched them out and injured them. Plan on a solid 6 weeks for that injury to heal. With a broken bone, we always tell people 6 weeks. So with a bad ankle sprain, plan on 6 weeks. The most common demographic for a tendon or ligament injury in the United States is a middle-aged man playing a pickup game of basketball. It's the most common demographic where we see injuries from this chapter, and it's usually a sprained ankle. Pickup game of basketball. Other sports are more dangerous, but not as many people do them, like mixed martial arts, for example. Middle-aged men doing sports they shouldn't. They tend to tear ligaments and tendons. So a sprain is an overstretch of a ligament. Possible that you tore it. A strain is an overstretch of a muscle or tendon. We can just get a massive bruise. A massive bruise is called a contusion, a muscle contusion. And then bone fracture, you actually break that bone. Can have a neurovascular injury, and that means either the nerve or the blood vessels were involved. The nerves or the blood vessels were involved. Bone fracture healing takes place in stages. Stage 1 is the inflammatory stage. You might have a little bit of bleeding around that bone that's broken on the inside. Stage 2, we have granulation tissue formed, and fibroblasts are attracted to the area of injury. That's really part of the immune system that's heading down there to start the healing process. Stage 3 then is callus formation, and then synthesis of extracellular organic matrix. In general, once you break a bone, that bone is not as strong as it once was. And so part of that is due to that callus formation. The callus is not as strong as it used to be. And you'll hear people say when the weather changes, they can feel their old broken bones. So if they've had broken an arm 20 years ago, on a cold, rainy day, it might start hurting again. And we think that's due to that callus sort of still not quite the same as it was before the break. So then stage 4 is strengthening and ossification, which means it's turning back into bone. Stage 5 is the remodeling stage. It's the final phase that involves remodeling of the bone at the site of the fracture. Hopefully, it will be strong enough to use in 3 to 6 months, but these things take time. There are common types of fractures, closed fracture versus an open compound fracture. The closed or complete is where the bone fragments separate completely. The open fracture is where the bone protrudes outside of the body. So you got a broken leg. It's usually lower leg. It's very common. If you've ever hit your shin bone on something, you know how much that hurts when you hit your shin bone. That shin bone is very close under the skin, just right there under your skin. So imagine how easy it is for that to just pop through the skin a little bit. So an open compound fracture is a much bigger emergency than a closed fracture. Once that bone pokes through the skin in the lower leg, most common spot, we're at a high risk for a bone infection. So imagine you wreck your car, maybe it's a snowy day, you slide off the road into the ditch, not a major car accident, but your leg just happens to break. For a lot of people with a lower leg fracture, that bone will pop out of the skin and then pop right back in. And so all we see when we're assessing the lower leg is what looks like a cut on the skin. So if somebody has a broken lower leg, and we know it's broken because we did an x-ray, have a broken lower leg, and it looks like they have a cut on their skin, they have to be treated for a possible bone infection, what's called osteomyelitis. And we just call it osteo. Osteomyelitis is a bone infection. That's technically in the next chapter in this book. But that patient is a high risk. And if that patient also has on their list of health problems, if they have diabetes listed as a comorbidity, they're a diabetic patient, broke their leg, they're going to lose that leg. They are going to get a bone infection and that leg will get amputated. So the open compound type of fracture is something we have to automatically mentally think about infection, the risk for infection. Was that a dirty wound? Did they get dirt in that wound? If so, they're going to go to surgery and wash it all out under a sterile field and usually start high-dose IV antibiotics and treat it totally different than a closed complete fracture where we just put a cast on and send you home. An incomplete fracture, some of those bone fragments are still partially joined. Compression fracture is a fracture that consists of crushing of cancellous bone. Most common that we see, and we see this all the time, is your vertebrae in your spine, and usually in the elderly, they can get a compression fracture. And often they don't even have to fall or injure themselves. They can get a compression fracture in their spinal column simply from the osteoporosis, where they have lost bone density because no weight-bearing exercise, and then the weight of their own body kind of compresses that vertebrae, causes a compression fracture. Transverse fracture is where parts of the bone are separated but still close to each other. Comminuted fracture that will have more than one fracture line and more than two bone fragments, which may be shattered or crushed. And we'll usually only see that on the x-ray. A stress fracture, usually caused by repetitive activity, and the most common stress fractures are new runners who put too many miles in too fast and get a stress fracture in their foot. Probably the most common cause of a stress fracture. Just hitting the pavement, and maybe you haven't ran for years, but then you go out and do 5-mile run, and then a couple days later another 5-mile run. Stress fractures will sideline your marathon training plan pretty quickly. So the antidote is just take it slow, take it slower than you had intended. And rather than printing off that 12 weeks to your first marathon training guide, do like a 1 year to your first marathon training plan to prevent the stress fracture. An avulsion is a separation, a complete separation of a fragment of bone. The green stick fracture I mentioned is often seen in children, and it's an incomplete break in the bone. And so if you think of a stick, if you have a stick that has fallen off of a tree and it's dried out over a year or two, those sticks break pretty easily. But a green stick, maybe you chop it off of a tree, a green stick doesn't break very easily, and that's actually the same in children, because children's bones are not hardened yet. And impacted fractures, one part of the fracture is compressed into an adjacent part of the fracture. So after a fracture, we start to see a callus build up within 6 weeks. It shows up on x-ray. We think that taking ibuprofen will slow down bone healing. Ibuprofen is an anti-inflammatory. It's a non-steroidal anti-inflammatory agent. Most of your orthopedic doctors won't prescribe ibuprofen anymore because it seems to slow down the bone healing process. They do give a lot of Tylenol, though. Tylenol is not anti-inflammatory. As far as the skeletal muscle healing, the myocytes are the name of the cells that make up your muscle fiber. You can have, if you injure a muscle, you can have injury to the nerves and blood vessels. And injury to the surrounding nerves and blood vessels play a role in return to function, because there's a chance if you cut a nerve, for example, in your forearm or somewhere, you might not be able to feel your fingers. And repaired muscle is not as strong as it was prior to the injury. This slide, I want to take a moment to digress a little bit. In this chapter, they talk about trauma. Trauma has its own life-saving measures that are instituted first. And it follows the ABCDE mnemonic. And I would encourage you to answer all test questions in healthcare type exams following this mnemonic. You might have an exam question that says, what's your first priority? What's your first priority? no matter what the question is, your first priority is always airway. Airway. If it's a car accident patient, we add the phrase with cervical spine protection. I will open the airway while maintaining cervical spine protection. Airway. The very second priority is breathing. Breathing. So this is kind of interesting because breathing is actually not the number one priority. The airway is. And so this will help you. This is how I answer all of the test questions I personally take is I go back to the A, B, C, D, E. An example could be a patient is choking. A patient is eating steak and suddenly he is turning blue and he's holding his neck in the universal sign of choking. Is breathing the priority? He's not breathing, but the correct answer is the airway is the priority. If we don't open that airway and get that piece of steak out of his airway, he won't ever start breathing again. When I first learned this was after nursing school, and I took a class called, I'm gonna Google it here and see if I can pull it up. Trauma Nursing Core Curriculum. That's where this slide on the PowerPoint came from. The TNCC, the premier trauma nursing course for nurses and hospitals worldwide. Every second counts when stabilizing life-threatening trauma cases. Prepare yourself by taking TNCC. And I would encourage you to do that. It's hands down the best class out there. I took advanced cardiac life support before I took TNCC. And TNCC just completely opened my eyes. It opened my eyes to a systematic, easy to understand way of dealing with any single patient. And my instructor way back in high school when I was an EMT student, my instructor always said that ignorance breeds panic. Ignorance breeds panic. And what that means is you only get scared if you don't know what to do next. If you're working in healthcare and you don't know what to do, that ignorance breeds panic. And the TNCC can mitigate that problem because you suddenly know exactly what to do with every single patient. And the first thing to do, open the airway. This TNCC, I mentioned this, I think, last week, but this was founded in Lincoln, Nebraska. The very first trauma curriculum was developed at Lincoln General Hospital. And it's now just basically required of any nurse all around the world who's taking care of the trauma patient. TNCC, Trauma Nursing Core Curriculum. They got an 8th edition out of that textbook, but I wouldn't go buy the textbook necessarily. I would get a job that would pay you to take the class because it's kind of expensive. I think it's like $400 or something. Anyway, TNCC. That's where this slide in the book about major trauma, this process is called the TNP, which is the trauma nursing process. Trauma nursing process. The D, disability, is kind of confusing. They were just looking for a word that started with D, but it just is your neuro evaluation, your neurologic evaluation. So disability, simple thing to do is ask your patient, hey, how are you doing? The patient says, I'm fine. Do you know where you are at right now? The patient says, I'm at St. Elizabeth Hospital in Lincoln, Nebraska. And if they're correct, and that's the hospital they are in, then they just passed their disability evaluation. Then with trauma, the E stands for exposure, which really just means cutting all of their clothes off. Cutting all of their clothes off. And so over here at the SCC bookstore, you can buy what are called trauma shears. They're scissors with a blunt tip that are specifically designed to cut people's clothes off. Because if you don't expose the patient completely from head to toe, you're going to miss an injury. That's called exposure. And so we actually do a full head to toe at that point in time. First, we stabilize the airway, we stabilize the breathing, we stabilize the circulation, we check how alert and oriented they are, D, and then we cut off all their clothes and check for an injury that we missed. And I've seen crazy injuries that we missed until we cut the shirt off. The reason we're doing all this cutting is the patient is usually immobilized on a backboard with a rigid cervical collar in place. Cut off those clothes. And then that's when we notice, oh crap, he got stabbed 10 times in his chest. We didn't notice. Or whatever it might be. I got in trouble one time. I sent a routine car accident patient down for a CAT scan. And no, it wasn't even a CAT scan. It was just an x-ray of her pelvis. A young lady, we didn't cut her clothes off because she seemed fine. We're like, she's fine. We'll just send her down. Well, the doctor got mad because on the x-ray of her pelvis, she had in her pants, hidden in her pants, an 18-inch hunting knife. We couldn't see any of the bones because the knife was right there on the x-ray. It was probably that long. But we had not done our job and exposed her. So then because we just cut this person's clothes off, the environmental control means we got to keep them warm. We cover them right back up. Make sure they don't have a gunshot wound that we missed or a knife wound that we missed. The exposure. I also got burned on that on the mental health unit too, because that's skin assessment. The skin assessment is a vitally important part of every patient's assessment. I had a young man who we did not look at his skin because he was 20 years old. He's fine. He doesn't have no pressure sores. Didn't worry about that. But what he did have, which we didn't know but found out, was he had an obsessive compulsive skin picking disorder and had picked a hole through his belly and his intestines were showing. So never take for granted that your patient's skin is okay. You always have to do the full skin assessment, the exposure. That comes from the trauma nursing process, which is part of TNCC. Other things we check for are pain, tenderness, swelling. We check the color. We check capillary refill, joint range of motion. We look for any swelling, redness. Range of motion could be passive, which is where the examiner moves the joint. Could be active, where the patient uses his or her muscles for movement. Crepitus is the clicking of a joint. We usually think of crepitus as the sound of bone on bone, bone on bone. And that's kind of a creepy sound, kind of like the sound of fingernails on a chalkboard. Crepitus. X-rays, ultrasounds, DEXA scans, CAT scans, MRIs. The X-ray is good at seeing non-soft tissue. So if you've got a muscle injury, we won't see it on an X-ray. The X-ray is good at looking for bone, broken bones. So if you have a soft tissue injury, the X-ray won't show anything. The difference between a CAT scan and an MRI is the CT, the CAT scan, is just a whole bunch of little X-rays. So the CAT scan is just a bunch of X-rays. And so the CAT scan is also not good at seeing soft tissue injuries. It won't, a tendon problem or a ligament problem or a muscle problem won't show up on X-rays, and it won't really show up on CAT scans for the most part. If you have a soft tissue injury, you're going to need a MRI, magnetic resonance imaging, because that shows soft tissue. Most injuries are self-limiting. RICE is the acronym that we use: rest, ice, compression, and elevation. So you have a musculoskeletal injury, stay off of that foot. I said foot because I broke my foot this month. I have a broken foot right now, actually. The doctor said, you need to rest and ice it and try an ACE wrap. ACE wrap, that's what compression stands for. An ACE wrap and then elevate it. That's RICE therapy. Do memorize that acronym. You'll see that all the time. You'll see it on exam questions from here on out in every class. What do we do for broken bone? RICE. Rest, ice, compression, and elevate. Then the surgeon will fix the break. A closed reduction means a device is worn on the outside of the leg or the arm. An open reduction means they actually cut the patient open. An open reduction, internal fixation, is probably the most common that we see in the hospital for hips and different breaks. That's when they cut open your arm and put internal hardware. So bolts and screws, the internal fixation. With any orthopedic injury, the risk for a deep vein thrombosis, a DVT, and the risk for a PE are sky high. So any patient on any orthopedic floor needs to have DVT prophylaxis. Let me know what that big fancy word prophylaxis means. This means prevention. DVT prophylaxis. And the two most common things that we use, early ambulation is the best prevention. If we can get that patient up walking immediately after surgery, that's the best. If we can't get them up walking immediately, they're going to get Lovenox shots. So anticoagulant therapy, Lovenox shots. You guys that are doing checkoffs for fundamentals probably had to give a Lovenox shot, I bet. Did you guys? Did you? Anybody in fundamentals right now? Are you in fundamentals? No. As part of the medication checkoff, you have to give a Lovenox shot. And Lovenox is it's like heparin. Heparin is a anticoagulant to prevent deep vein thrombosis. Prevent that DVT. Some types of fractures can actually lacerate the artery running by there. That's a huge problem. Not only do you have a broken bone, but you have a arterial bleed. So the best thing for us as healthcare providers is to assess the neurovascular status. And that just means check the pulses. If somebody broke their leg, check their pulse in their feet. It's called a pedal pulse. See if they can feel you touching their feet. If that nerve or blood vessel gets cut or lacerated or compressed, then that muscle tissue can start dying. An extreme example of that is compartment syndrome. Compartment syndrome. This is a confusing concept. I would encourage you to read this little bit in the book and see if you can figure out what they're talking about. Compartment syndrome. But basically what compartment syndrome is you've got swelling. You've got tissue swelling. But here's the kicker. The swelling is on the inside and it has nowhere to go. I'm going to draw a picture on the board. See if we can make sense. See if we can make sense of compartment syndrome. Let's say this is a cross section of your lower leg. You have two bones in your lower leg. You have your tibia and your fibula. That's a bone. But then your lower leg has compartments. You know that you have your calf muscle. We'll say this is the front of your lower leg. So this is your shin bone, tibia. This is your calf muscle, which has got a fancy name, gastrocnemius. You don't need to know that, I don't think. Gastrocnemia. Glare is right there. But deep inside your lower leg, you have compartments. These compartments are just muscle fibers, but they're surrounded. The muscle fibers are surrounded. I drew a little person, didn't I? I didn't even intend to do that. That little smiley face. Imagine this smiley, that sad face is your lower leg. Deep inside your lower leg are compartments. If you get swelling in your calf muscle, you'll notice you got swelling on the outside, and you look at your leg, it looks all swollen. But if you get swelling deep inside in these compartments, that swelling has no place to go. It just builds pressure, builds higher and higher pressure. That high pressure inside this compartment cuts off the circulation. The blood vessels going to feed that muscle. The pressure shuts them down, clamps them off. And so if you have a muscle that's not getting any blood flow, what do you suppose your symptoms would be? And sure enough, on this slide, number 2 bullet point on this slide, the patient complains of pain out of proportion to the degree of injury. And this person usually will be in excruciating pain. Excruciating pain, 10 out of 10 pain. But then when you look at the lower leg, you don't see any swelling. You don't see any redness. Everything looks fine. Doesn't make any sense. And then you do an x-ray. You x-ray the leg. But keep in mind, the x-rays do not show soft tissue injuries. So x-ray is perfectly fine. There's no swelling on the outside. It's not red. The patient complains of 10 out of 10 pain though. And the problem is we're gonna think that they just want narcotics. That's how messed up we are as healthcare professionals. Oh, he's just an ARC seeker. He's just an ARC seeker. But in reality, that muscle tissue is dying. And we have to treat the pain and figure out what's actually going on. So how do we diagnose compartment syndrome? We have to measure the pressure inside that compartment. The way we do that, we don't do it as nurses, but the doctor, the orthopedic surgeon, will take a giant needle and stab it right into that compartment. Big old needle, boom, stab it right in there. And on the end of the needle, he has a little pressure dial, just like your blood pressure cups. And it has little numbers on it and a little thing, and it says, boop, pressure is a 10 out of 10. Holy bucket. That's compartment syndrome in a nutshell. We can only measure it by stabbing the compartment with a needle, or doing an MRI probably could show it too, but then how are we gonna fix this problem? We have to relieve that pressure. The way that we relieve the pressure is the surgeon takes a big old knife and cuts into the compartment. And they just chop the compartment all the way down its side, called a fasciotomy. And then they'll leave it open. So a person with compartment syndrome will have, depending on how far the compartment syndrome is, they'll just have these incisions on probably 3 or 4 sides of their leg, all the way down the leg. And then we just leave it open. And so they're usually in the hospital because we change the dressing a couple times a day, and it might take weeks for that to slowly heal. Compartment syndrome. Patient complains of pain out of proportion to the degree of injury. Another orthopedic trauma situation that we actually see quite a bit. We see this a lot now that everybody's doing CrossFit. Everybody does CrossFit now. They go join the CrossFit gym, and I'm a big fan of CrossFit, but the workouts are so crazy and intense that they can cause massive amounts of muscle tissue to break down, called rhabdomyolysis. This used to only be seen if somebody was in a terrible car accident and pinned under the car for a period of time. So if you've got a pickup truck laying on your legs for 2 hours, you have a lot of muscle breakdown. What happens when those muscle cells break down, the inner contents of those cells spills out into the bloodstream. And that content is called myoglobin. Myoglobin. We measure that on your blood work with what's called a CK, creatine kinase level. So by definition, you have rhabdo if your CK is sky high. Sky high. The problem with rhabdo is all of that myoglobin plugs up your kidneys. Kidneys try to pee it out. It's a big molecule. It plugs them up. Plug up those kidneys, the kidneys shut down. So people with rhabdo tend to die if their kidneys shut down. Any questions on rhabdo or compartment syndrome? I would say those two concepts are the most difficult in this section. Rhabdomyolysis, compartment syndrome. They're the most difficult concept, but also probably very important to understand. If you can understand compartment syndrome and you can understand rhabdo, you will pass the trauma nursing core curriculum exam. I just happen to know both of those questions are on the exam you take at the end of TNCC, trauma nursing core curriculum, which you have to take if you want to be an ER nurse. We did talk about DVTs and PEs. Those are blood clots. The blood clot in your leg is called a DVT. When it travels to your lung, it's a PE. But there is a different type of embolism that can occur in a broken bone. If you break a long bone or one of your really big bones in your body, like your femur or your pelvis, those bones have a lot of fat in them, and you can develop what's called a fat embolism. And that basically means fat globules from your bone marrow enter your blood vessel and shoot right up there to your lungs. And fat embolism can be fatal. If somebody breaks their hip or pelvis and then just dies an hour later, it's almost always because of a fat embolism. Just randomly die an hour later. Avascular necrosis. The only times I've seen this are in little old people with a broken hip. You break that hip bone, and by hip bone, I'm talking about your femur. You break that femur, sometimes it can lacerate that blood vessel. You cut that blood vessel, and now that bone is not getting blood supply, and it will die. Avascular necrosis. I'm skipping a few slides. Talk about ankle sprains, and the big thing is RICE. RICE is the treatment for an ankle sprain. Rest, ice, compression, and elevation. The stress fracture I mentioned, repetitive stress on the bone, and this is usually often from runners. Extensive micro damage is what we think causes it. The stress fractures may not be apparent on the x-ray initially, and that's true of any broken foot bone. Any broken foot bone is actually very hard to see on x-ray unless it's super displaced. Carpal tunnel syndrome is a cumulative trauma disorder. And this is in your wrists and carpal tunnel from typing. If you do a lot of keyboard work, I would encourage you to get an ergonomic split keyboard. If you're writing the great American novel on your laptop, you're going to get carpal tunnel syndrome. I'm going to go back a few slides because I wanted to mention cervical strain and sprain. On the etiology this is neck pain. We're talking about neck pain. On the etiology of neck pain, whiplash, that makes sense. That's when you're rear-ended by somebody at a high rate of speed and your head snaps back. You pull some of those ligaments and tendons. But abnormal posture is the leading cause of neck pain now. And what do you suppose is causing that? Your phone. Worldwide, there's a pandemic of neck pain now because all of us spend so much time hunched over our phone. And I talked to a physical therapist about this, and he said absolutely every 80% of the patients he sees at his physical therapy clinic come in with cervical pain, neck pain, and then he sees them in the waiting room, and I do this constantly trying to work on it. In the waiting room, hunched over their phone. Like, oh, that's why you have the pain. It's an abnormal posture. It's an abnormal posture. Ideally, the antidote would be to hold your phone up at eye level when you're looking at it. Keep your posture straight. Stress fractures, carpal tunnel, tennis elbow. I can't imagine that you'll take care of somebody in the hospital with tennis elbow, but bursitis. These are the aches and pains that we all get when we're older, for sure. Temporal mandibular joint also. I wanted to point out the hip fracture because a lot of people think that the hip is its own bone. The hip is just talking about your femur, where your femur ties into your pelvis. So if you fracture the neck of your femur, that's a hip fracture. It's a hip fracture. Same with the intertrochanteric fracture, the hip fracture. The subtrochanteric fracture, they might just call a proximal femur fracture. That's usually what I see the surgeons write on their surgical consents. Is a proximal femur fracture, and then if you break that bone down farther, closer to your knee, they'll call it a distal femur fracture. But a hip fracture is just a femur fracture, but it's up there close to where your femur joins your pelvis. Very common due to osteoporosis. We do see younger people breaking this area, usually from car accidents. If you hit head on, high rate of speed, if you imagine how your feet are sitting against the floorboards of the car, that's a very common fracture. If your legs are pushed back, you can get all kinds of weird compression fractures and different things like that. But by far, the most common hip fracture is an elderly person with osteoporosis, and they break their hip. And often we don't know if they broke their hip before they fell or after they fell. It's very common. If you're 80, 90 years old, it's very common to be walking along, break your hip while you're walking, and then fall. And so often we don't know what came first, the chicken or the egg, and it's due to osteoporosis. Best way to prevent osteoporosis, even though it's very difficult to prevent, but weight-bearing exercise, and also calcium and vitamin D. The big thing with hip fractures is we have to immobilize that person. And so Don't try to get them by yourself. Just call 911. Just call 911 because the paramedics have perfected the art of scooping somebody up with a hip fracture off of the sidewalk. They've got the tools, they've got the equipment. And if you're trying to throw your grandma into the back of the car and she has a broken hip, it's going to be excruciatingly painful. Just call 911. And those guys, they do this every day, hip fractures. The problem with the elderly and the hip fracture is it's often a death sentence, mainly because of the immobility. It dramatically impacts their ability to walk around. And very often they will then die shortly thereafter. This is a slide showing that vertebral compression fracture, a compression fracture in your spine, again, most commonly due to osteoporosis. This is why I'm a DNR. So if I code, please don't start chest compressions on me, because chest compressions and vertebral compression fractures go hand in hand. If you didn't have a compression fracture before we started CPR, you will have tons of them after. The collarbone is one of the most common childhood fractures. It's often a green stick fracture. So the collarbone is your clavicle. The distal radius fracture is usually from falling, and you can break it two different ways. You either fall on a hand that's flexed, or you fall on an outstretched hand, extended hand. Extended hand is called a Colles fracture, and a Smith fracture is usually due to a flexed hand. And then the tibia and fibula often fracture together. Tibia fractures, that's your shin bone in your lower leg. They may be open because only a thin layer of skin covers that bone. We call them tib fib. You got a tib fib. If you got a bilateral tib fib, that means you broke both tibia and fibula in your lower leg and both lower legs. Bilateral tib fib is not uncommon from those car accidents at a high rate of speed where you head on somebody. Foot fractures, rotator cuff. Rotator cuff is confusing because it's just a whole constellation of muscles and ligaments and tendons that all tie in to keep your arm in its shoulder. So your rotator cuff, you could have a tear of a tendon. Really, one of the leading causes of rotator cuff injuries are hypertrophy of the mirror muscles. What that means is people bench pressing. Bench pressing is an unnatural ergonomic movement. It does not translate to the real world, but people bench press all the time. Bench pressing over time moves your shoulders forward. As your pectoral muscles get bigger, it moves your shoulders forward, and those shoulders no longer have the range of motion. And so most fitness instructors and coaches will encourage you to never bench press. It's not anatomical. It's only for show. It's called a mirror muscle exercise. And somebody that bench presses for 10 years, 20 years is going to get a rotator cuff surgery in their late 30s or 40s. Very common cause of rotator cuff. And the phone thing also contributes to rotator cuff because of the rounded shoulders, and also knowledge workers who sit at the computer. The bad posture, the rounded shoulders contribute to the rotator cuff injury. And they go out and play a pickup game of basketball and tear their rotator cuff.